So, what are our treatment responses in custodial settings? Well, first of all, if we give out leaflets, they'll get ripped up. We trialled this with our new head of healthcare. We said, we've got to do something about the waiting area, still affectionately called a holding cell, and it is a cell, there's a locked door on it. I said, what I want to get into is interactive media, you know, DVDs, these sort of things, because this is really where the evidence base is for people with literacy difficulties and socially excluded, that watching things, seeing things leads to behaviour change over and above leaflets. She goes, well, should we just try leaflets anyway? I said, yeah, let's try leaflets anyway, because this will be fun. All the officers were saying, we can't wait for this. And sure enough, all torn up, ripped apart, and whatever happened, it was like sort of, what was that stuff? Paper mache. When we had postcards, none of you remember paper mache anymore, but the postcards used to get ripped up with bits of glue and made into paper mache, and lovely little masks and things when we were kids. I'm getting all romantic and sentimental now, but anyway, there was paper mache in the corner, throwback to my childhood, and so we then put the DVD in, and guess what happened? Somebody nicked the end of the TV. And they had it down in prison. We still have suspicions of the staff, but anyway, I put encourage testing, and then I'd like to put this in light touch wherever possible. The ideal is that we test everybody, that it's a full screening programme. The reality is we haven't yet got that joint working from the last Venn diagram between primary care, between prisons and community, whereby we can hand on test results. So there's an ethical dilemma of, if we do a test but can't inform the patient the results, does that then create a problem? Yes, it does. And the answer, I think, again, is in better care pathways within prison and community, both coming in and being released. And you know, I put here telephone answering, written confirmation, and it's not too big a problem when you think about it to get around. We just need to get the right bodies around the table. Shared care, I'm absolutely convinced, is the way forward. I have the dubious honour with the Royal College of Psychiatrists of doing a training on personality disorder with a much more eminent than me and Professor of psychiatry, and we were sort of bumbling through our first two pilot ones of, you know, what's the right way to go here with our audience, who mainly consultant psychiatry with primary care and secondary care, and lo and behold they hit us on our second one that shared care is the way forward, because the psychiatrist is very much coming from, again, the consultant psychiatrist needs to coordinate everything. We're grappling with this, but we're missing so much unmet need in primary care, so we came up with how GPs can better identify PD, refer into secondary care, and then take on some of the shared care management. And I'm absolutely convinced this is the way forward for our services. We also need to deliver alongside opiate maintenance treatments. I think this is the missing link, the missing trick. We've got bogged down in, should we be treating current injectors, and that all gets really politicised. You know, a bit like, should we be doing graft replacements on people who still smoke, and it's not an argument that I think as clinicians we can really win in the foreseeable future, but I think we can say people who are treatment engaging really well and have a long time treatment on opiate maintenance, these people are demonstrating commitment to accessing treatment services. These people should be a high priority for antiviral treatments. Remember Hep B vaccination, I'm glad it's a service user coming soon, because when I've been working a whole year with drug users, and I just found out what hepatitis C was, because I'm also too old to have been trained. I was trained before Hep C came along, and they said don't forget Hep B vaccination, and it's always stuck with me that, you know, in this it should be one of the first questions we're asking. Okay, I've got 2 minutes 24 seconds remaining. It does really go quick, doesn't it, when you're enjoying yourself? So as I've said, my one take-home message is let's get this antiviral treatment alongside opiate maintenance. There are general practice clinicians prescribing opiate maintenance shared care schemes. Just bolt on the antiviral treatment, sounds easy. The problem is prison-based opiate maintenance is under threat for political reasons. Many voices now want to see recovery. Many in the field suspicions that it's a Trojan horse for abstinence and therefore time-limited opiate maintenance. We did an RCT of methadone versus buprenorphine, and we pooled the data in a descriptive fashion. In fact, actually how many became abstinent at 8 days. So I'm not saying 8 months, just at 8 days in the prison. Just less than 20% were actually abstinent at 8 days. So these people, as I said, socially isolated, low self-efficacy, are they really going to become abstinent in the foreseeable future? Long term, yes, but short term, still will always be a role for opiate maintenance. Psychosocial support, please don't shut me down over that term. I know sometimes people hate the term. By that I sort of mean, you know, not the medication, not the pharmacology. It's patchy, but the evidence base shows good outcomes if we offer therapeutic community interventions in prisons. How can we tie it into Hep C? 1 minute 2 seconds remaining. Dual diagnosis, because it is all about comorbidity. Dual diagnosis in prisons is a significant challenge. I direct you Centre for Mental Health website because they do some great stuff, and they say greater accounts of comorbidity, co-training, prison diversion schemes. People don't even come into prisons. But if you're in prison, offender behaving programs can reduce the risk of re-offending. 33 seconds remaining. Please go away with the message. Much is being done in prisons. Work with your local prisons. We have significant organisational and logistical barriers that we're seeking to overcome. But you know, we're doing our bit, and we really want to get into this shared care working around hepatitis C treatment. They're the references to show. Hopefully it's not all been my own opinions. And I'll finish with 5 seconds to spare. Thank you for your time.